Hello, good morning, everybody. This is Dr. Vivek Loomba here. I'm a pain management physician, and today we are going to discuss about cancer pain management. Today's topic will just briefly outline the various medical aspects and about cancer pain, and in subsequent topics we'll go into more details on the same. Now, first of all, coming to the disease itself, as we all know, cancer is a very debilitating disease, and a lot of these patients survive the disease for a large number of years now these days with improved medical management, and these patients may also suffer from pain. The causes for pain could be manifold. One of the most common cause, the cause could result from the tumor itself. It may be a bulky tumor which is pressing on the adjacent organs, resulting in pain. Another cause could be from the metastasis. The tumor metastasizes to various organs, where again it compresses the adjacent structures, and this can cause pain. The bone pain from some tumors is very notorious and could be very hard to manage. It could be the pressure on the various nerves which can result in the pain. The pain could also result from various fractures secondary to osteoporosis in these patients. It could be the multiple causes for the pain in these patients. What can we do for this? The first and foremost comes seek help. Seek help. Go find a pain physician. He'll help you get better. Patients are a lot of times reluctant to seek help for the pain management. And again, this could be due to several reasons. Very commonly, I see that the patients and their loved ones, they tend to believe that it is a part of the disease. They're going to live with the pain. There's nothing they can do about it. So this lack of awareness is a big thing. However, there are so many things we can do these days to help these patients get better. And another is, it could be a lack of referral. The oncologist or the oncosurgeon, sometimes he may not be aware of the disease, of how bad you're suffering from the pain. So you need to inform your oncologist or oncosurgeon. You need to tell those guys how bad you are, how severe your pain problem is. If it is causing you lack of sleep, if it is causing you lack of mobility, it could be from the disease itself, or it could be from the pain. So you need to make them aware, and then they can refer you to a pain physician. Another reason could be financial constraints. A lot of these patients, they have already spent millions on the treatment of the disease itself. Now, when the pain issue arises, they tend to manage it themselves. Avoid going to a pain physician, trying to save money. However, they are very cheap. There are cheaper alternatives too to manage this pain. So please seek help. Even with cheaper modalities, it may make your life significantly better. Now, coming to the next step, once the patient has actually sought help, what do we do next? So these patients, once they come to clinic, first and foremost is the assessment of the pain. Assessment. This assessment includes the cause of pain. Where is the pain coming from? The tumor, the metastasis, the pressure on the nerves, or the fractures. What are the causes of the pain? And secondly, it is the assessment of the severity of the pain, how severe the pain is. This is usually done by various pain scales. We have the numerical rating scale, which is very commonly used, in which we assess the pain. We ask the patient to grade the pain on a scale of 1 to 10. We jot that down. On next visit, it is helpful to help us in the prognosis and to tell us how successful we are with the current regimen, whether we need to upgrade or downgrade the medications for pain management. There are various other scales like the visual analog scale, like the non-verbal scale, loads of others. The pain physician will take care of this. So once the pain is assessed, then comes the next step: how to manage it. The simplest and the most commonly used method is the WHO pain ladder. What is a WHO pain ladder? What it basically means is go with the least potent, the safest drug first, and if that works, great. If it doesn't, go to the next level. If that doesn't work, go to the next level. That's what it is essentially. So to start with, we give acetaminophen, the paracetamol, to manage pain. If the patient still comes back with pain, then we give to the non-steroidal anti-inflammatory drugs like ibuprofen, and there are loads of others in the same family. You use one of those. If the pain continues to persist, then we go to the next level, which is the weak opiates like tramadol. If there's still not much improvement, then we can go to the stronger opiates like morphine and fentanyl. So we just grade and we go up the scale. Then there are a lot of adjuvant drugs like SSRIs, the selective serotonin reuptake inhibitors, the SNRIs, the selective norepinephrine reuptake inhibitors, then the anticonvulsants like pregabalin, gabalin, etc. So we try to combine these drugs, go one up the other, and eventually, once the patient feels better, we try to stay that. And then another aspect of this letter is we give it by the clock. By the clock means you give it around the clock. You don't wait for PRN. You don't wait for the patient to start experiencing the pain before you give it. So give it around the clock. You give it by the mouth, so that is preferred to give oral medications rather than intravenous or intramuscular medications. And once the patients feel better, then you keep on that regimen. Then once we are done with these medicines, there are some other things we can use, like the topical, like some capsaicin or menthol, some other aspects some other medications we can use locally, which apply on the skin. By this multimodal, multi-pronged pain management techniques, the patient will feel better. Now coming to the adverse effects of these drugs, most commonly nausea, vomiting, constipation, headaches. They are the common minor side effects. The more serious ones could be respiratory depression, etc. But nausea, vomiting are the ones that bother the patients the most. To handle those, we can give routine, commonly used anti-vomiting agents like ondansetron, the Ondem. For constipation, a good bowel hygiene is very important, and some laxatives can help, especially for patients on opiates, on a stronger dose of opiates. So all in all, the goal of this medication management is to make the patient's life comfortable and also the lives of their loved ones. Once the patient feels better, then it'll help him to boost his morale as well. And there's a huge improvement there. So that's all for today. We'll discuss some other aspects in the next talk. Thank you so much. Have a good day. Bye-bye.